Thank you for the introduction. It's a pleasure to be here today. Well, regarding psoriasis in the elderly, our patient was a 70-year-old man, and as you can see, his medical history was complex. He had multiple comorbidities, typical for this stage of life. But especially chronic kidney disease was a real challenge for us for treatment planning. He was taking several medications, and his psoriasis starts since adolescence, and over the years, he received systemic conventional therapies as well as phototherapy. Following the diagnosis of a high-grade urothelial carcinoma that required intravesical BCG, our therapeutical approach needed to change. And indeed, the patient had a flare-up of his psoriasis with erythematous scaly plaques on his low back, elbows, and also he has high-impact areas, involvement such as scalp and nails. So taking all these factors into account, we decided to start a Apremilast adjust to his renal function. At first, the treatment was satisfactory. His skin improves, but after a year of Apremilast, he lost efficacy and the PASI increased. So at that moment, it was necessary to start a biologic. So we performed some complementary studies, and we found an increased hematocrit and things that we had already known about his chronic kidney disease. But his tuberculin skin test was positive, something that is usual in Argentina, and both the chest X-ray and the CT scan were abnormal. This was the main challenge. We had to decide if the patient had an active tuberculosis, a latent tuberculosis in someone who had a chronic obstructive pulmonary disease, or if these changes could be related with intravesical BCG. Once active tuberculosis was ruled out, the infectious disease team recommended us starting prophylaxis for latent tuberculosis, and then we start risankizumab. This was evolution of the skin with a clear improvement over the weeks. But after 1.5 years, the patient developed eczematous skin lesions. So in that moment, we start suspecting a flip-flop phenomenon. The skin biopsy revealed subacute eczema. So we switched to deucravacitinib. But 8 weeks later, the patient contacted me with worsening pruritus, further extension of the lesions, but what really called my attention was the purpuric appearance of his plaques. At the same time, his hematologist, during a routine follow-up, found anemia, leukopenia, thrombocytopenia, and she decided to perform a bone marrow biopsy, and the diagnosis of acute myeloid leukemia was made. So deucravacitinib was stopped, and he initiated treatment for his leukemia. Despite all efforts, multiple infectious complications occurred, and the patient passed away 4 months after the diagnosis of the leukemia. So psoriasis is a prevalent disease, and as in many parts of the world, the demographic composition of Argentina is changing, and with increasing of life expectancy, the proportion of elderly people is increasing. The main challenges in this stage of life are comorbidities, polypharmacy that increase the risk of drug interactions, the greater chance of other events, and overall frailty. Something that everybody knows is that elderly patients are underrepresented in clinical trials, so most of the evidence came from real-world studies. These are the results of the BADBIT registry, and as we can see, elderly people had a greater chance to switch biologics due to adverse events. Another important thing is consensus, and in this point, the Spanish working group has been pioneer because they made a management recommendations for these special situations. In conclusion, treating psoriasis in the elderly is challenging, but people with moderate to severe psoriasis still need systemic treatment. So it's important to individualize the risk and the comorbidities. as evidence comes mainly from real-world studies, we need to share our clinical experience. The other important things, and to the end of the presentation, is that we need to continue working together to build guidelines that may help us in treating that special situations like psoriasis in the elderly. Thank you very much for your attention.